So, hi dear students, today's topic will be pharmacological characteristic of parenteral anticoagulants. And firstly, let's start from classification. So you see, anticoagulants can be parenteral, and parenteral classify on indirect thrombin inhibitors, heparin, then low molecular weight heparins, it's fondaparinux, and then direct thrombin inhibitors, it's for example lipirudin, bivalirudin, argatroban. Next, oral anticoagulants or coagulants, they can be coumarin derivatives, bis-hydroxycoumarin, decumarol, or warfarin, acinocumarol. Next, it's indandione derivative, it's phenindione. And next, direct factor 10A inhibitors, rivaroxaban, and oral direct thrombin inhibitor is dabigatran. So today we will speak only about parenteral anticoagulants. Firstly, you see factors of coagulation on the cascade reaction of clotting, and here you see two ways: intrinsic pathway normally and extrinsic pathway. So from 12 factor should convert to 12A, then due to 12A 11 convert to 11A, and then you see it's like cascade reaction. So what about mainly heparin? You see in red color, in a red red color. So heparin will will inhibit 12A, 11A, 9A, and especially 2A factor thrombin. Direct thrombin inhibitors like argatroban, bivalirudin, dabigatran, they inhibit primarily 2A factor. So heparin. About history, something. MacLean, a medical student, discovered in 1916 that liver contains a powerful anticoagulant. Howell and Holt in 1918 named it heparin because it was obtained from liver. However, it could be used clinically only in 1937, when sufficient degree of purification was achieved. Heparin is a non-uniform mixture of straight-chain mucopolysaccharides with molecular weight from 10,000 to 20,000. It contains polymers of 2 sulfated disaccharide units. So that about effects of parenteral, especially anticoagulants. So mainly it's anticoagulant effect first. Mechanism of action. So firstly, they should combine heparin with antithrombin 3, and then this complex heparin antithrombin 3 binds to clotting factors of the intrinsic and common pathways. So and inhibit 10A, 2A, 9A, 11A, 12, and 16A factor. And low molecular heparin, so low concentrations heparin, they inhibit primarily 10A factor. What we can mark that low concentrations of heparin prolong activated partial thromboplastin time without significantly prolonging prothrombin time. High concentration prolong both. So next, antiplatelet effect. Inhibit heparin in high doses inhibits platelet aggregation and prolongs bleeding time. And then lipemia clearing. So injection of heparin clears tubular post-parenteral lipemic plasma by releasing a lipoprotein lipase from the vessel wall and tissues, which hydrolyzes triglycerides, chylomicra, and very low density lipoproteins to free fatty acids. These then pass into tissues and the plasma looks clear. This action requires low concentration of heparin than that needed for anticoagulation. Pharmacokinetics of heparin. So heparin is a large, highly ionized molecule, therefore not absorbed orally. It should be injected only intravenously. Heparin doesn't cross blood-brain barrier, placenta barrier. So this means that this is the drug of choice during pregnancy. Then it's metabolized in liver by heparinase and fragments are excreted in urine. Heparin released from mast cells is degraded by tissue macrophages. It's not physiologically circulating anticoagulant. What about drug interactions? So heparin should not be mixed with penicillin, tetracycline, hydrocortisone, or noradrenaline in the same syringe or infusion bottle. Heparinized blood is not suitable for blood counts, fragility testing, and complement fixation tests. What about dosage of heparin and low molecular heparin? Heparin is conventionally given intravenously in a bolus dose of 5,000 to 10,000 units. Children from 50 to 100 units per kilogram. It should be followed by continuous infusion of 750 to 1000 units in hour. The rate of infusion is controlled by activated partial thromboplastin time measurement, which is kept at 50-80 seconds. So low molecular heparins, they can be given in 5,000 units and is ejected every 8-12 hours, started before surgery and continued for 7-10 days or till the patient starts moving about. Adverse effects. So bleeding, it can be due to overdose, the most serious complication of heparin therapy. Hematuria is generally the first sign, but with the proper monitoring, serious bleeding occurs only in 1-3% patients. Thrombocytopenia occurs due to aggregation of platelets. Occasionally, serious thromboembolic events result. In some patients, antibodies are formed to the heparin platelet complex and marked depletion of platelet occurs. So heparin should be discounted in such cases. Even low molecular weight heparins are not safe in such patients. Then alopecia can be, osteoporosis can be, and hypersensitivity, for example, urticaria, Rico fever, anaphylaxis. Contraindications. So from adverse effects, again, bleeding disorders, thrombocytopenia, severe hypertension, endocarditis, large malignancies can be risk of bleeding because of risk of bleeding in the central necrosed area of the tumor. Tuberculosis, so risk of hemoptysis. Ocular and neurosurgery lumbar puncture, chronic alcoholic cirrhosis, renal failure, and with aspirin we shouldn't give heparin. So low molecular heparin, about this, heparin has been fractioned into low molecular forms, so molecular weight from 3 to 7,000 by different techniques. Low molecular weight heparins have a different anticoagulant profile and they selectively inhibit factor 10A with a little effect on 2A. Differences: low molecular heparins and unfractioned heparin. So low molecular heparins have a small effect on APTT. So because those we can calculate due to body weight basis. They have less antiplatelet action, less interference with hemostasis, less side effects like hemorrhagic complications, like bleeding, like risk of osteoporosis. So then they are eliminated primarily by renal excretion, and so but these drugs can be used in the patient with renal failure. They have more long action Better subcutaneous bioavailability 70–90% if we compare with heparin 20–30%. Indications of these drugs, of all these drugs, it's prophylaxis of deep vein thrombosis and pulmonary embolism, treatment of established deep vein thrombosis, unstable angina and myocardial infarction, to maintain patency of cannulae and shunts in dialysis patients. And about synthetic parenteral anticoagulant fondaparinux, it inhibits 10A factor like low molecular heparin, bioavailability higher 100%, metabolism is minimal, and it's largely excreted and changed by the kidney. So same, it shouldn't be used in renal failure patients. Fondaparinux is less likely to cause thrombocytopenia compared to even low molecular heparins. Risk of osteoporosis after prolonged use is also minimal. Fondaparinux doesn't require laboratory monitoring of APTT, and it's a long-acting alternative to low molecular heparins. Dose 5–10 milligrams daily. So, and the last about heparin antagonist, it's protamine sulfate. It's strongly basic, low molecular weight protein obtained from the sperm of certain fish. So dose that should be given, it's 1 milligram for each 100 units of heparin. Thank you for your attention.